Me and Nealon go back 7 years now. He's worked with the Mariners. That's where I got introduced to Nealon, and he knows everything about physiotherapy. I think the common growth-related problems that we see a lot at the school. We had a lot of conversations about how can we get better as a school within the injuries. So whoever gets injured in my training group or my group, I always send them to Nealon and Patrick. So his full name is Andrew Nealon. Works with, he owns Aspire Physio Center in Holgate. And he has a partner now, it's Patrick Fleming. He's been working there now for a few months, 6, 7 months. They are going to show us a video or PowerPoint presentations about every problem that we can come across, and gives a little bit of in-depth about how we can recognize common growth-related problems, small injuries that will still need attention by physiotherapy instead of us. Nealon's worked 5 years with the Mariners at now, and I think he stopped as of 2 months ago. He was 2 years at Liverpool, and before that I think he was with Shane Warne a little bit in cricket as well. So there's a lot of knowledge about professional sports, not just football, also in different sports. Patrick, I don't know much about his background, but him working now with Andrew, I heard a lot of good stories about him from a lot of patients, including my wife recently. So if Macca wants to go there, I think you'll be in good hands. All right, thank you. I'll refer you to Andrew now.
Thank you, Patrick, for that detailed introduction. It's nice to see some familiar faces. A few ex-Mariners and a few has-beens and a few wannabes as well. So it's we have a good relationship with the school. We've looked after a number of the kids with their injuries, and we pride ourselves on communicating well with the coaches, so that the coaches that have players that have problems, they have a clear understanding of what they, not so much what they can't do, but what they can still do in training, and try to keep players that may have various niggles or problems doing as much as possible. We're not into ruling them out. We want to rule them into doing as much as they can do. So that communication is really important, and thanks to the school for the invitation to come up and talk today. What I wanted to talk about today and help educate people on is, obviously in football things happen. You know, it's a contact game. Injuries happen. It's part and parcel of the game. We go to great lengths in the professional setup to try and stop injuries happening, but the reality is that some still do occur. I think in recent years we've made some pretty good strides in terms of reducing the numbers of certain types of injuries that can be prevented, but there are some things that just happen. Obviously that was a bad day for Storm in a completely non-contact situation, just trying to block a ball. He dislocated his shoulder and broke his ankle in the one go with no one anywhere near him. So things can happen, and then in contact situations, things happen as well. But the focus today is not so much about that type of random incident. It's more about the types of things that happen when kids are growing and playing a lot of sport. So there's a few things I want to get across today. The main thing is that kids' bodies are different to adult bodies. And because they're still growing, they're vulnerable to certain types of injuries that we can't really prevent. But we can manage quite well if we know about them, and kids are educated in terms of how to manage those sorts of problems that don't necessarily need to keep them out of the game. So that's really the focus of the talk today, is about growth-related stuff, things that happen when kids start to shoot up in growth, in conjunction or in combination with high levels of activity. So it's a combination of those two things that tends to cause the types of problems that most of us, that we commonly see, and we've seen a number of players from the school with these types of issues. So what we'll hope to be able to do by the end of the talk is to help you identify the signs of the common growth-related conditions that typically respond very well to simple things and simple management strategies. These things get managed very differently to even 5 years ago or 20 years ago when I first started as physio, and as a kid growing up, we didn't know a lot about this sort of stuff. So a lot of the aches and pains that we just used to put up with, kids today often still just need to put up with at times, but we can manage them much better, and it doesn't need to affect their football or their sport as much. I also want to talk a little bit about the early warning signs of lower back stress fracture. Before I started working in football, I spent 10 years working in cricket and played cricket a lot growing up at a decent level, and lower back stress fractures you probably hear most about in the press relating to cricket. Pat Cummins and James Pattons and Brett Lee and guys like that. The really fast bowlers, they get these types of injuries at the highest rates, are the most common, but they're more common in football than what you might think. And we've had 4 or 5 from within the school in the last couple of years, and a couple that we're managing at the moment. So the signs of that are not always recognised, and that can have some consequences, so we'll educate you about that as well. And then the other injury that we want to talk about, because its management has changed a lot in recent years, it's very topical at the moment, obviously with the contact footy codes, rugby league and rugby union, AFL, but also more and more in our football as well. The management of concussions changed hugely in the last couple of years, partly due to improved medical research and partly due to massive court cases. And at both of those scenarios have really changed the way we manage this at the professional level, and I think it's really important that that's trickled down to the junior levels as well. So we'll talk a bit about that. So firstly, the growth-related conditions. Essentially, they're an overload of the attachment of where tendons are tissue that links your muscle to bone. It's like a cable or a cord. It's at the end of each muscle. And when bones are growing, we tend to find that it's quite common to end up with this tug-of-war situation that causes pain. In a young growing body, we have growth plates. So the growth plates are these lines here. In a way, they look like a crack. Okay, this is a recent patient of mine. And they're not actually a crack or a fracture. If that was an adult, something's broken. But in a growing kid, that's normal. And this little space here, the little black line, is cartilage. And cartilage looks different to bone on an X-ray. It's from those bone factories or those growth plates, that's what makes us taller. In some people more than others, obviously. But that growth plate there, the one at the top of the shin bone, sort of arcs down to the front here, the top of the knee, which is a really common site of pain. The growth-related conditions are typically associated with kids when they're at their highest growth rates, going through their growth spurts, combined with a lot of activity. So if they're growing quickly and spending their whole day sitting on an iPad playing at a computer, they're probably not going to develop this sort of pain. But yet you could have someone who's not growing that quickly, but playing a lot of sport or with a sudden increase in how much sport they've got on, like a carnival or a camp or joining the football school, for example, where they've got to jump in their load. That tends to be a common trigger for these types of pain. The pain's usually associated with running, jumping, quickly starting and stopping, and often the surface as well. So you see a lot of it in obviously basketball, netball, like your hard court sports. Often when kids are playing more football on the artificial surfaces, or futsal over the summer, where there's a lot more tighter spaces, more twisting, turning, starting and stopping, less running overall, but the harder surface. Thanks to Brad Porter for donating his leg for the picture, freshly shaven. So there's a few different sites of these common pains. So we'll start with the first one. Osgood Slatters, it's the term that gets thrown about is disease. Disease, by definition, means something that you can't cure. And we can't cure the fact that a kid's got a growth plate. So they get called disease. But I think disease really overstates or makes the problem sound a hell of a lot worse than what it is. So we tend to call it, use the word syndrome. We'll try to downplay it and take a bit of the fear and the worry out of the injury, because it's really nowhere near as bad as that. Osgood Slatters is... Sorry, you're not seeing that, but I am. Computer problem. Osgood Slatters is where the quadriceps or your quad muscles stick onto the top of your shin bone. And this would be the most common growth site of pain that we see, especially in boys. Often sort of, age 10 and upwards, they often get a little bit of a bump or a lump at the top of their shin bone that's really, really quite tender. So we'll just go through the different sites, and then we'll go through a little bit more about what they are and what we can do about them to ease the pain that goes with that. So Osgood Slatters is the most common. Probably second most common, or similar really, is severs, which occurs where the Achilles tendon meets the heel bone, often sore by the direct contact of a football boot or getting kicked or a little bump. That often occurs a little bit earlier, where the calf muscle sticks on. There's another one, these people just name these things after themselves, obviously, back in the day. Sinding Larsen Johansson's at the pointy bit of the bottom of the kneecap, where the patella tendon meets the patella or the kneecap. And then least common, but we've had a couple of these lately, it's called Island's. It's at the base of the fifth little toe bone in the middle of the foot on the outside. Basically, all of these things are caused by the same factors, and they're all associated with growth, and they're all associated with activity. So they get grouped together, and the way we treat them is really similar. Slightly different, obviously, because they involve different muscles, but the principles remain the same. So how do you know if your kids or your players have got these things and what to do about them? The sorts of complaints you'll hear about is pain. Pain's the most significant complaint to hear about. They don't come to us and usually complain about anything other than pain. And it's the pain is at that attachment site. So where those grumpy faces were on the previous slide, that's where the pain is. It's very, very localised. That's one of the features of these types of problems. They're tender to touch. So a kid with Osgood Slatters won't like to kneel on the floor to do his shoes up because it'll be sore to kneel down on. If they fall and land on a hard surface like a futsal court or even the ground, if they're sore enough, or get a bump or a kick, get whacked with a ball, they hurt. They're sore to touch. They're often sore at the start of a training session and take time to get going. And in that sense, they're actually really similar to an adult with a sore tendon. Someone with Achilles tendinopathy, or what we used to call tendonitis. Often sore to get going. Then once you get going, it feels a bit better. And then they may be sore at the end if their tendon overload's getting a little bit too painful. But you'll often see them at the start of a session, they'll hobble around. Particularly with the heel pain, the severs, kids as they get out of bed first thing in the morning will often get out of bed and not be able to walk freely. They'll walk either on their toes or they'll walk on their heels, but they won't want to sort of heel toe and walk naturally as they get out of bed. Instead of getting out of bed like a 10-year-old you think's full of beans ready for the day, they get out of bed hobbling around like their old man. And in their football, you'll often see, because these muscles are involved in making us jump and push off and accelerate quickly, the pain slows them down. So often the kids at one season might look good. They suffer a loss of speed, agility and sharpness. Again, just like the older player with a sore tendon. And then the other thing that you might see, particularly mostly with the Osgoods, is it feels hot. It's an inflammatory pain. So anything that's inflamed often feels hot, might look a little bit red. And they get this characteristic, or often get this characteristic bump just on the top of the shin bone there. And that's nature's way of growing more bone to try to hang onto that tendon. So that tug of war I mentioned before, there's pulling away of the tendon at the growth plate attachment, that's what causes the pain. And then nature thinks, well, if that falls off, that's a bit of a problem, so we better do something about that. So in an adult with a sore Achilles, they'll just end up with a really fat, thick Achilles tendon. That's nature's way of trying to reinforce something that's weak to stop it from breaking. In the kids, they basically grow bone out to try to hold onto this, and it looks a bit like a spur, like a heel spur might look in an adult. That usually goes down, but often kids that get a good dose of this will always have a bit more of a bump, a bit like someone who's broken their leg will always have a thicker bit of bone over where the body's fixed it. As I said, these are benign problems, which means that they're not going to go on to have problems as adults. Kids can often have really painful, quite debilitating growth-related pain that slows them down and hurts a lot, but once their growth plate's fused or their bone's fully formed, they're not going to have pain anymore. It's very, very rare to have troubles as an adult associated with this. So it can seem quite painful and quite serious at the time, but managed properly, it usually settles pretty well. So we'll talk a little bit about that now. The first thing you've got to do is identify it, and the feature of these types of problems is usually really localised pain. Where it hurts is usually a pretty obvious sore spot that's sore to touch. If you don't let it go on too long, it generally doesn't get so sore, and it doesn't take as much time or work to calm it down. So picking it up quickly is important part of getting over it as well. Like any tendon pain, especially in an adult, managing kids' problems is the same. It's about managing load, and that's something that certainly the professional game has evolved a lot in the last few years, but basically it just means not doing too much and then not having sudden changes in quantity. So the body's a very resilient thing. If someone's used to running 100 Ks a week when they're training for marathon, they can cope with 100 Ks a week as long as they build up to that gradually and their body gets used to it. These types of pains often flare up when seasons start. So we've seen a fair bit of this in the last couple of months. Kids come out of their summer sports. It might be obviously less football, nippers on the sand, playing cricket, or less running around over the summer, more time on the beach. And then football season starts. All their programs start, whether they come back to school at the end of January up here, and then the Mariners programs get going, the CCF academies get going, local football starts, and we tend to see a spike in these types of pains. Kids may have grown a bit more over the summer, and they've not had this pain because they haven't been doing so much. But then when you add in the sudden jump in activity, we tend to see this problem quite frequently. It's important to recognise, especially for the parents as well and the kids, we're not going to stop you if you've got this pain. Our goal is never to stop anyone. Our goal is to keep people going, doing whatever they're doing. That's our job. That's what people come to see us for. So don't feel like if you put your hand up to get help, you're going to get stopped. With a growth-related condition like this, I never stop anybody. 30, 40 years ago, kid with Osgood Slatters, they would put in a plaster cast if you had it bad enough. They would do it just to stop you running around. And then people worked out that doesn't really work, because when you come out of the cast after 6 weeks, you've just got a chicken leg that's even skinnier than what it was before. You're just as tight as what you were before. You're still growing. So the tug of war that's going on hasn't changed. You've just stopped running around, so the pain settles. But then you come out of your plaster cast, get back into your football and get back into running around again, and you've just induced a big sudden spike in activity, and they often end up worse than what they were before. That still does happen frighteningly. I saw a 12-year-old girl 2 weeks ago who had probably the worst case of osgood-Schlatters pain I'd ever seen, and it was only last September that she was put in a knee brace for 4 weeks by an orthopaedic surgeon, which for that type of pain in 2016 is completely unnecessary. And 3 or 4 months later, after stopping dancing because she couldn't cope with that anymore and taking up soccer instead, she just got the same pain back again. So within a week or two of just her not running around and playing anymore, we didn't tell her to do that. Her pain had already told her to do that. Her pain settled and she's now back playing again. So managing the load and trying to take out the peaks and the troughs, or the big jumps and drops in how much you do, is a really important part of managing this. At worst, kids may need to prioritise how much they do. They might need to decide that 4 sessions at IFS plus 3 sessions with the Mariners Academy plus 2 games on the weekend, for example, might be a bit too much for them at the moment. And they may need to scale back what they do for a while and prioritise and just do the most important things and keep them playing their games. But once they're coping with that, then we gradually ramp it back up again and try and get them back in, try and get them doing whatever they need to be able to do. The coaches here will have seen a number of patients that we've seen doing holding type exercises, with the kids doing holding type exercises before the warm-up. So if they've got severus pain, they might be standing halfway up off their toes on 1 foot holding for 30 seconds. Or if they've got Osgood's pain, they might be doing a sitting squat up against a wall or a goalpost or a tree for 30 or 40 seconds. Those types of exercises have been shown to be really effective for easing tendon pain in adults, and it works just as well in the kids. But doing those types of exercises, the 3 or 4 minutes that might take, can make that warm-up sauna so much better. Kids can get out of the blocks and ease into their session so much better with much, much less pain. That's an option we didn't even have 4 or 5 years ago. That's recent research that's changed what we do and given us a great option for managing this type of problem. It also helps turn those weak, lazy muscles off that pain shut down, such as your calves and your quads. And we often get the kids doing those exercises again in the evenings just to calm their pain down. So it's an option we didn't really have before. The tug of war we're talking about is basically caused by the bone grows quickly and the muscle's just hanging on as well as it can at each end. And at one end, they tend to be painful. Obviously, to get that muscle longer, so it can be long enough for the bones that it's now attached to, you've got to increase its flexibility. But it's really important to get the timing right. So we're very careful with stretching. Years ago, we tended just to get kids stretching with these types of problems. Again, that's changed as we've learned more and we've learned from mistakes. So at the right time, we definitely want to try and increase the length of the quads or the calves or the hamstrings or wherever the pain's coming from. But we've got to get it got to do that at the right time, which is important. Otherwise, we can flare them up. And then the other thing which we often need help with from the coaches is reminding the kids to regularly ice their sore spot. Try to have your fun, play your game, run around, do what you've got to do, but then calm it down so that for next time you're ready to go again. And icing regularly after activity is a really important part of managing an acute, sore, inflammatory pain, which is what these are. It's a good pain reliever, but the cumulative effect of allowing this pain to build often catches up with kids. And if they can just get on top of it every day or two with some regular icing, plus or minus a bit of Voltaren gel just on the sore spot, that can be really a really effective way. And then finally, the other sorts of things we do with these problems is try and reduce or improve their shock absorption. So not as much force gets to the sore spot, so that sore junction of tendon where it meets the growth plate doesn't have as much load to deal with. So sometimes little heel raisers, sometimes little shock absorbers, sometimes orthotics, sometimes strapping and taping and stuff like that, or a little brace. They're the other options that we have as well. But the main key to looking after these things is being consistent and just keep chipping away. Kids can be taught, if they understand why they're doing these things, to look after these problems pretty well. They're not going to do it because I said so. They're not going to do it because mum and dad said so. They're not going to do it because their coach said so. They need to do it because they understand the relationship between what we're asking them to do and feeling better. And once you've proven to them that they will feel better with this stuff, then they will be compliant. They will look after themselves because they want to play. And they'll soon see the relationship between taking 5 minutes to settle their pain down or to warm their problem up and being able to continue playing, which is what they want to do. So we tend to say to them things like, if you want to do what you love, you've got to give your tendon what it loves. And the sore tendon doesn't like running around and jumping and landing and stopping, but you like that. So if you want to do that, you've got to give the tendon what it needs and come to some sort of deal, because otherwise, quite commonly, the pain will stop them. And that tends to be when we see them. They usually don't knock on our door until they can't go any longer. And that's the purpose of today, is try to help people understand what are just kids' complaints to brush off and go, yeah, you'll be right, get over it. And what are the sorts of things that can be helped without the kids fearing and the parents fearing that we're going to stop them playing. because that's absolutely not what we're about. So it does require a team approach. Kids need reminding. They may need help getting their ice pack. They may need reminding to do their stretches. They might need help setting up their rubber band for their particular types of exercises at home. But if they experience the improvement, then you'll find that they'll do what they need to do. So that's the common growth-related stuff. Now I'm going to talk about some less common stuff that is more serious. We don't see it anywhere near as often. And to be honest, I wasn't even going to mention this until a couple of weeks ago, where we've seen 2 of these types of injuries in kids from the school, and I had one other one as well, all at the same time. Basically, that tug-of-war, very, very rarely does it come to this. And in the kids that get these types of problems, they usually haven't had any pain beforehand. So if you've got severs pain, the likelihood of your Achilles falling off is almost nil. But if you're a 40-year-old who decides I'm going to play football or basketball again, then they're the people that tend to snap their Achilles. In these types of things, they're not the kids that have had the pain, and most of the time they happen around the pelvis, where your hip flexor muscles or your hamstring muscles stick on. So the growth-related conditions tend to be at the other end, like down at the heel or down at the knee. The avulsions, or what we'll define them as, basically where the tendon pulls off the bones, where it comes away. Okay. Rarely we see these injuries in adults, rarely, but more commonly you see these things in kids. So we've got 2 patients at the moment who are from up here. We obviously won't mention names, but these things just happened, and you can't stop them, you can't prevent them. They just happen. It's just it's a random bit of bad luck. But basically, the quadriceps, where it sticks on, comes off the pelvis, and it takes a little bit of bone with it. So you see it on X-ray, which I'll show you in a moment. They're important to identify because they need to be really managed well. So a kid with Osgood's pain, if he's got it for a couple of weeks before anyone helps them, or a couple of months, and sometimes even a couple of years, it's not the end of the world. It's not going to really cause them problems as an adult. These types of things, if they're managed properly early, won't cause them problems as an adult, but they'll cause them problems for a good while, for up to a few months. So it's important that they're identified when they occur, and they're pretty obvious, especially if you know what you're looking out for. And they need to be, as I said, if they're managed properly, they're generally not a problem. Not in the long term. So what are you looking out for? It's sudden pain at an attachment site of one of your major long muscles, as I said, usually around your hips or your pelvis. 1/3 of these injuries happen where your quads stick on, basically just at the front of your hip here, and we had one of those in a young player recently. 1/3, I've actually never seen one of these ones, but 1/3 of them happen to the hamstrings where they come off, which is the sit bone, the bone a bit of your bum that you'll sit on a hard seat. That's where your hamstring comes off. I've seen a couple in adults, but not in kids. And then the ASIS is just long term for basically the pointy bit at the front of your hip here. And I had a boy about 7 or 8 weeks ago kicking a football, that tendon ruptured off the bone, and he'd been taken to the hospital and they checked it out. And he was actually back playing fairly quickly, about 6-7 weeks, but he was also like a big lad, almost 17. It's unlikely to occur when they're almost sort of fully grown like that. But because I think he was closer to being fully grown, it was a quicker recovery. But in the younger kids, tend to see it more in the 13, 14-year-old age group. And they happen with something happening suddenly, like an explosive, a takeoff, kicking a ball, like trying to smash a ball, slipping. It's common, like they're slipping and they go into sudden hip extension, or the leg goes behind them suddenly, or they get tackled and pushed, or they're reaching for a ball, trying to bring a ball down and reaching behind them, or pushing off quickly. So if one of those sorts of things happens, then generally, the kid's down. They're not getting up in a hurry. It hurts a lot. They may hear or feel like a pop or a crack with it, and there'll be sudden, usually intense pain. They're not going to be able to continue to play, and they're probably going to struggle to walk. They'll have a big loss of power because one of the muscles that used to attach the bone to pick their leg up isn't attached anymore. Now, over a short period of time, a few days, usually they'll start to be able to pick up again, not because that muscle so suddenly attached back on again. So this little bit of bone here, that shouldn't come out like that. That should be just stuck on here. So on an X-ray, that's what one of these looks like. That's where the quadriceps comes off. But the quadriceps, the rectus femoris muscle, which is that guy that's come off the bone there, it's only one of 4 quads, obviously. So within a few days, they'll be able to pick up their leg a little bit using their other muscles. But when it first happens, the shock that comes with the pain tends to turn everything off. And that's nature's way of saying stop and go and get some help. And these kids need to get looked at. They need an X-ray, and very rarely do we need to do any more imaging than that with MRIs and things. Usually the X-ray and the story that they will tell is generally very clear. Together with a few tests, like if you lie on your back, can you lift your leg up? And typically they can't even lift their leg off the table. So it's usually pretty obvious. The other one I want to talk about is lower back stress fracture. So obviously my background in cricket, we see there's a lot. They're really common in elite cricket and fast bowlers, but they're more common than you might think in the footballers. In the Mariners Academy this season, we've had 3 or 4 across the 4 age groups from 13 to 16 at various stages. Either kids have recovered from them or they're recovering at the moment. So they do occur more commonly than what you might think. They occur in about 5 to 10% of boys as they're growing up. So they happen in the general population. They're more common in more active people. They're more common in sports that involve a lot of leaning backwards, like gymnastics and cricket fast bowling. But in football, there's enough impact. If they're running around enough and they're growing fast enough, these sorts of things happen. And they tend to happen in that 14 to 15 age group, sometimes a little bit younger, when kids are growing at their quickest. Most commonly growing at their quickest. Your bones grow in length quickly, and it's like there's not quite enough bone to go round. So the long bones get longer, the vertebrae get bigger, and there's a little bridge of bone in the part at the back of the vertebrae where these injuries occur that for a time is very, very vulnerable. And it's vulnerable because there's just not enough bone to go around this new body that's quickly expanding and lengthening in size. When a male is at 90% of their adult height, that part of the vertebrae that gets a crack in it with a lower back stress fracture is only at 50% of the density or the hardness or quantity of bone you're going to have as an adult. So if you're an old lady who'd fallen over and broken a hip, they call you osteoporotic. They say you're osteoporotic, and they probably put you on medication and maybe put you in padded pants and stuff like that. So if you fall over, you're not going to break your hip. But this part of the bone in kids is just as vulnerable through these age groups. And there's nothing we can do about that. The other thing that tends to happen is while they're growing quickly, and you'll see this as coaches all the time, kids go through what I call the baby giraffe phase, where one year they might look like really fluent, good athletes with good running technique. They might look like good players, and the next year they come back in February and they're 3 inches taller and they look like they've just lost the plot physically. Their coordination's gone out the window. Their agility is not what it was. They're taller, yet they're slower. They don't move like they did. And that's a time of pretty inefficient body movement where your bones have grown quickly, your muscles are hanging on, and as a result, everything's not quite in sync like it was before. And when you combine the growth rate with the poorer running technique, they don't shock absorb quite so well, they don't hit the ground as fluently, in conjunction with a jump in activity, in conjunction with just overall quantity, these types of things can happen. And so the things to look out for are these. So I'll put all these up in one go. These are the early warning signs that as a parent or as a coach or as a young kid, you may recognise some of these. And I put this slide up when we did a similar talk to this at the Mariners Academy a couple of months ago. And there were 2 boys in the room out of 4 teams that came up afterwards and said, I think that's me. So by educating people, we don't cause stress fractures, but we help people identify them. And it's important that they're identified so they get managed properly. If you broke your leg, it hurts a lot, it looks a bit weird, you go and get an x-ray, you go into a cast, it gets managed. These types of fractures sneak up on us. They're not as painful, and if they are as painful as like a broken leg, they're very much end stage and all of these signs have been missed. But often they're quite a pretty minimal bit of discomfort. It usually just starts out with a bit of stiffness. And you'll often see kids, again, you'll see it more in cricket maybe after they've bowled a ball, but they want to stretch forwards. So if you see your boys and girls down on their haunches or squatting down because they probably don't even know why they're doing it. They'll do it instinctively because they're sore from the impact or they're feeling stiff from the impact, and they'll like to go the other way. They'll crouch down or they'll bend forward or they'll sit on their haunches and they'll get back up and they'll run around again. Or they'll bowl the next ball or they'll get back into play. So if you sort of see that in back play, or a kid that they all like to sit and slouch, but backs with these types of problems are happy to sit and slouch. They don't like leaning backwards. If you see that they just don't look themselves, they've lost their sharpness, they've lost their fluency, don't move around so well, that's another sign that you often see. They start out with stiffness and then they get sore, and the pain is usually initially unique to sports. It only hurts when they're running around. Once they stop, they feel okay before they start to get worse. So if they say, I just saw what I'm playing, I'm all right, but that's often an early sign, and then they'll be sore afterwards, and then they'll be sore at night, and then they're sore in the morning as they go through the spectrum of going from a little stress reaction to actually the bone starting to crack and crack through. They may be sore on one or both sides of their back. They may be sore on one side. We had one of the boys up here who'd been sore on one side for a while. That pain went away over the futsal season where he wasn't running around, like less running around impact. And then he got sore on the other side. And it was only when he got sore on the other side, it was like, oh, this is bad enough to complain about. And then he came and got some help, and we saw a current stress fracture and an older stress fracture, one on each side, which has different implications as well. If you see a few of these signs and you're sort of saying to young Johnny in your group, what's going on? He says, my back's a bit stiff and sore. Get him to lean backwards. And if he leans backwards, particularly on one foot, and it hurts on that same side, that's a really common sign that there's trouble brewing, and it might be like, well, maybe you want to go and get that checked. He might say, I've been having treatment or having a massage or seeing the physio or whatever, and it's just not getting better. That's often a sign, again, that it's going on and it hasn't been identified. But they like rest. They like to stop. So we've got to be careful not to get sucked in by, I feel better on a Monday because I've had the weekend off, if it's over the off season, for example. It's an overload problem. This is what they look like on a scan. So the picture on the left, basically, this is what bone looks like on an MRI scan, on that type of image. That's what it should look like. And this one was in a 13-year-old boy who was a young cricketer. You can see the really bright white spot. So if you look at the vertebrae above it, that's pretty grey-black, that's pretty grey-black, and that's bright white, and that's a crack. And that's what an acute lower back stress fracture looks like. And as I said, they're much, much more common than you might imagine. This is a recent scan of a young player, and you can see on this one, basically you got L5, which is the bottom vertebrae, and L4. Patients lying on their back when they take these types of pictures. So this is the left and this is the right. That's what the bone should look like in those. So 3 out of the 4 are fine, and see that one's bright white. That's what an acute just happened stress reaction. And that patient's only had pain for a couple of days. Pain for a couple of days. Coach said, oh, that's not quite right. Kid's like, yeah, it's pretty sore. Had a jump in load, recent carnival, come and get help. Saw us on Friday. That's a picture on Tuesday. So hasn't had pain a long time. But if that had gone on, then she would get a crack in that. Okay? So the pain doesn't have to go on for that long, but that one's been picked up quickly. So what do? The most important thing is, if you suspect one of these things, like I've said before, we're not into taking kids out of their sport, and we're not. But the biggest barrier to their development is a prolonged period of time out of sport. So if they need a day or two to get checked, relative to being out for months or two or having a month added onto their rehab, then a day or two is not really that long a time, especially in their growing years. When they're 18, if they've still got problems because they had a stress fracture, didn't get detected or get managed properly, that's what's going to harm the development. Being left out for a day or two to go and get checked when you're 14 or 15 is really not going to make a day's difference when you're 18. But if you have one of these problems that doesn't get sorted out, then it can have big implications for your career. So it's important that they don't wait for a few weeks rest. If they have a few weeks rest, they'll feel better. Within a couple of days, the patient whose picture that was there before feels miles better. They all feel better with rest. It's an overload problem. So rest makes them feel better. What's important is that they get enough rest and they get their problem identified so that a couple of days or a couple of weeks rest is not wasted when what they needed was a few weeks more or another month more. There's no point having 6 weeks rest when you need 8 and then playing at week 7 and going right back to the start again because it didn't get long enough to heal. So they all feel better, and it's really important that they get checked out during that rest phase so that the rest doesn't lure us into a false sense of security. If you see any type of practitioner, they say the pain is muscular. Muscular pain in lower backs in kids is as rare as hen's teeth. There's no reason why a 12, 13-year-old kid will strain a muscle in their back. It just does not happen. It could happen, I guess, but it doesn't happen in my experience. Kids get bony stuff. Kids get growth plate stuff, they get bony stuff, they get cartilagey sort of stuff. And they get certain sorts of problems, like I said before, because they're kids. So if the practitioner says it's just a muscle strain or it's just a bit of a stiff facet joint, the likelihood of that being correct is really, really low. If a kid came in and rattled off 4 or 5 of those warning signs that I mentioned before, and they're sore to lean backwards, especially on one foot, and especially when we twist them a bit, and they're sore to touch on the bone in their back, then I'd be banking my house on the fact they've got a stress fracture before they're not. We treat them as a stress fracture until we know they're not one, because it takes us a few days to find out whether they are or they aren't. But if it's muscular, or you just need your back clicked, or I can put that back into place, or we can rub that better, it doesn't happen. So just be aware of those types of comments that someone might, or the GP might say, and it's not the sort of thing that GPs typically see. They've got a million things that are more serious than this to have to concern themselves with. Oh, it's just a young sprain, he's just young, he'll be fine. Don't accept that as an answer if you're a parent of a kid complaining of these things. Insist on imaging. We can't say with certainty that someone has a stress fracture. No clinical test will say for sure, if you do these tests and they say that, they've definitely got one. But like I said before, I could count on one hand in 20 years how many times I've thought they are and they're not. It's really quite uncommon. By the time they come to see us, they're usually well down that path, and they're sore enough to be getting help. Those warning signs have probably not been heeded. Sometimes they are, but they're only not been heeded because people didn't know any different. So by the time they get to us and they're telling us those things, we're very, very suspicious, and we have to rule it out. That's what we're trying to hopefully do, is rule it out. We'll say to the player and their mum and dad, I think they've got this. I hope I'm wrong. I'd love to be proven wrong. I hope it's unnecessary. But what I'm going to do is write a letter to your GP. If your child's under 16, Medicare will pay for an MRI scan for unexplained back pain. This meets the criteria of unexplained back pain. So once they've had an x-ray, they have to have an x-ray first. If the x-ray is clear, which it almost always will be, by the time you see one of these on an x-ray, you don't have a stress fracture. You have a fracture. It's got a crack in it. Otherwise, you don't see it on the x-ray. Then Medicare will pay for the scan, okay, if they're under 16. If they're over 16, you've got to pay for it. It's $250 generally to get an MRI scan. But that's a small price to pay, relatively speaking, compared to the consequences of having one of these problems that's not picked up. Like I said with the x-ray, if it's normal, don't accept that as conclusive. The early diagnosis is really important, and I put this picture up because these things are really common in young kids who present with pain when they lean backwards, and it's really important they get picked up early. Stress reactions take 6 to 8 weeks to settle down. Cracks take 10 to 12 weeks. So it's a big difference between a stress reaction and a stress fracture in terms of how long it's going to take to get better. And what we don't know, and I put this picture up briefly because it's pretty ugly, what we don't know is where you are on the spectrum from having a normal bone and a broken bone. No one can tell us that. The only way we can know that's with the imaging. What you don't want to be is this guy. And I put that picture up because he would have had a stress fracture. He probably had pain. He's training for an Olympics or whatever it was, and he would have known he's got a sore shin, but he's thinking, this skin comes around every 4 years. I'm going to run the gauntlet and see how I go. And hop, skip, and a jump, and bang. And there was a similar scenario with a guy at the Olympics on the vault at the most recent Olympics who ran in, and exactly the same thing happened. So we don't want that to happen to our kids. And if it's missed, this is what it looks like on a CT scan down the track, where they've got a permanent defect with a great big gap of bone here. That's never going to heal. Doesn't mean it will always be painful, but it's likely that that person's going to have problems. And then if you get one vertebrae starting to slide forward on another, that's what happens if that occurs, or can happen as they get older. Now, there are players playing professional sport all over the world that may have recovered from this type of problem, but there are countless people that you never heard about whose back stopped them. Okay? It's the type of thing that's important that it gets picked up. You've got a much higher risk of longer term problems. Now, concussion, I just want to go through fairly quickly. The management of concussions changed a lot in the last few years. Certainly my time working in football, 5 or 6 years ago, concussion was dealt with as a knock. Players went back on the field with head knocks all the time. The world has changed enormously around concussion. It's a brain injury. It's not just a knock. Bones get knocks. Brains tend to not cope so well with knocks, and head knocks are injuries to skulls, and brains rattle inside skulls. Things happen. If you've seen the movie Concussion, which was about the discovery of a lot of the degenerative brain diseases that have occurred in gridiron players in America, it was a story of what led to what is a multi-billion-dollar enormous lawsuit where thousands of players are suing the NFL. People will say straight away, this is football, this is not gridiron. Those guys wear big helmets and lead with their heads and run into tackles and that sort of thing. That's a fair point, but they also don't head the ball from a small age all the way through adulthood. Our game does have risks associated with it. We play the game regardless, we take those risks on. I'm not saying we shouldn't, but when concussion injuries occur, the management has evolved a lot, and it's evolved because of the threat of huge legal action, and it's evolved because of the discovery of medical information. We don't treat heart disease and hamstring strains like we did 20 or 30 years ago, and concussion doesn't get managed like it used to either. So this is a bit about how it's being managed now. And I know we're talking with the school at the moment about looking at adopting a concussion policy that's been adopted, certainly at the Mariners Academy, which is simply pretty much a carbon copy of what the FFA have brought in for the way the injury is managed in the A-League. It is different across the different football codes, and it is different in our game, certainly professional level, where we don't have the head bin, we don't have replacements, we don't have head substitutes for people to go and get checked with concussion. We've only got 3 subs and all those sorts of things. Those sorts of issues have merit in the professional level. When you're talking about kids, there's really no reason ever to not manage this type of problem really properly and how it should be managed. So if a concussion is suspected, quite simply, the player's out for the day, at least for the day until we know that it's not a concussion. And if it is a concussion, then it gets managed thereafter. The other thing that's changed is that the management of concussion's been put in the hands of the doctors. Team physios don't deal with this injury anymore. It's the doctor's responsibility. And that's because it's a medical injury. It's not a muscle and bone and a joint injury. The doctors have training that we don't, and so the ball gets put in their court. And it's also because of the medico-legal side of things. Somebody has to be responsible for the management of concussion, and the various codes and governing bodies have said that should be the doctor. And I agree with that. In our game, there's not a mandatory you're going to be out for 2 weeks like there is in young rugby, for example. There is a return to play process, which I'll skip through in a moment, and that necessitates 6 days to get back to play. So it's not you've had a concussion, you're out for 6 days. It's if you've had a concussion, there's a process to go through, and that takes at least 6 days. The signs of suspected concussion, some of them are pretty obvious. Loss of consciousness, not getting up, looking dazed, blank, vacant, appearing unsteady on feet, maybe misbalancing when you go to get up, falling out. All those sorts of signs are pretty obvious. If any of those signs occur, it's basically our responsibility as people that look after players in the game to say, you're not playing again today. The last thing we can do, which is what always used to happen, was ask the player, are you all right? Because the player wants to continue. If the player suffered a concussion, they're not the best judge of whether they are right to continue or not. Okay, so the game has changed in that sense. When I started working the game, if the players were right and they answered all the questions, they knew where they were and they didn't wobble and they understood certain questions and could respond quickly, then they went and they played on. But the world's changed. Those days are gone and they're not going to come back. The symptoms of concussion are often more subtle. So many times I've seen players who have sustained what has become then known as concussion. In the game, they displayed none of those other things. They continued to play and they looked fine. But yet later on that night, they may have started to experience these sorts of things. So if they've gotten up and they've played the game and they've been fine, it doesn't mean they haven't sustained a concussion. It may just mean that the symptoms haven't happened yet. Basically, the brain's copped the knock and it hasn't sort of started to get the swelling and the sluggishness and the fog that often comes later. So if these sorts of things, and I guess this is more for the parent who has taken their kid home from the game and that night they're not themselves, they're more irritable than normal, they're grumpy, they're off their food, they might complain of a sore tummy or nausea, they might say, I feel a bit foggy or feel just not quite right in the head. They might not like the bright light, they might walk in the dark room, you get home from your game in Sydney, flick the lights on and that's a bit bright, and they really struggle with the sensitivity to light. That's the brain going, whoa, that's a bit of a shock. These are the much more subtle things that you might see. Slowed reaction times. They might be playing their computer game and they're hopeless. They're slow. They're sluggish. Their coordination's not quite right. They don't react quickly. These are the things to look out for if your child has suffered a knock to the head. Nausea, vomiting is a more extreme example, but it's obvious when it happens, and that's a sign that they may have suffered a concussion. Now, concussions, they get better. They will get better. It doesn't necessarily mean you've got to rush to the hospital, but if you're not sure, yes, go and get medical help. Generally, they'll just observe your child for a while. The likelihood of suffering a catastrophic injury from a head knock is very, very low, but obviously the ramifications, if it does happen, are bad. So if you ever have concerns, yes, you should go and get checked. With the recovery, the important thing is, unlike some of the other problems we've talked about before, we can't accelerate the recovery of the brain. It's going to happen at the rate that it's going to happen at. We can't make it go quicker, but we can slow it down if we do the wrong things. Basically, what they need is rest. The brain needs rest. Okay? It's suffered a knock, it's suffered a shock, it's been rattled in its cage, and it needs to rest. That rest is not just physical, it's mental rest as well. It's been shown in studies that people that don't rest take longer to get better. Okay? And what we want is a quick recovery. And the mental rest might affect a player's schooling, where they've got to sit and concentrate for hours. They might be looking at a screen. And for the kids, that means get them away from the screens, get them away from the bright lights, get them away from having their brain stimulated by a computer game or a phone or an iPad or whatever. Get them away from the bright stuff. Resting mentally means getting away from having to think. Usually they're pretty happy with that. The majority of concussions, 7 to 10 days, 80-90% of them will get better. Kids can be slower. The studies would suggest that the kids take longer to recover. So we can't make them go quicker, but as I said, we can slow them down. And if we push them back too early, you can get what's called post-concussion syndrome, which is like a really long, slow to resolve hangover or an illness. You just don't feel right, and that can last weeks and weeks. And if that occurs, you can't make that recover any faster either. So identifying them early, like all the things we've talked about, is the most important thing, and then managing them properly is the most important thing after that. The return to play process is this. They need to have 24 hours of feeling completely normal. There's 22 different symptoms on a form that are associated with concussion, like headache, like blurred vision, all these sorts of things. When all those 22 things are completely normal and they've felt that way for 24 hours, they can start to get going again. So that's basically stage one. The concussion policy has in place that a doctor also needs to do a few checks on their coordination, their ability to recall things and remember things, and a few tests of how someone thinks, not just what they say. We can't completely trust, yes, I'm fine. We need to also check that they're able to recall basic things of some words that you tell them, that they can recite the months in reverse order, and a few things that might stumble some people if they're not able to think like they normally would. And when the doctor's happy that that's all fine, then they can start to do a bit. They do a light walk, light exercise, bike or swimming session when they're not working too hard. And if they're fine with that after 24 hours and that doesn't aggravate them, then they can start to run around a bit, but nothing. This is the introduction of physical stuff, but no mental stuff. So no decisions, no choices between where to run, just some easy running, no weights, nothing where you have to push too hard. Then if you're good for 24 hours after that, then you can start non-contact training where no body and no ball hits your head. You can start to do some resistance exercise, but start to think a bit. If you're fine after that, and the doctor says you're still fine after that, and again, this is not a policy that I made up. This is the FFA's policy that's been implemented certainly throughout all the A-League clubs, and the A-League clubs have to follow this. The club doctor has to sign off on the form. The club CEO has to sign off on the form to say the doctors follow the rules, and then that has to go to the FFA a minimum of a few hours before match time. And if those things aren't done, then the player can't play. And I don't see any reason why we shouldn't follow the same process with kids. And then once they've ticked all those boxes and they're fine, they go back to full contact training. If they're fine 24 hours after that, then they can play. And that's what takes 6 days. But if you stumble at any of these hurdles, you're back to square one. And that's what I mean about not rushing it. It can take a long time. It's like snakes and ladders. You crawl up that ladder, and if they stumble here and go, nah, I've got a bit of a headache, or they can't do their test properly, they can't recite things, they can't remember properly, then they're back to scratch, and you've got to start again. And I think it's really important that the parent is an active participant in making sure the process is followed, not trying to get around it so that the little Johnny can play on the weekend. And certainly in the Mariners Academy, we've got a part on the form that we introduced there that the parent signs off and says, yes, they saw the doctor twice. The doctor has to sign it there and there at those 2 stages, and the parent signs off and says, I'm happy to accept that my child's gone through the process and that he's right to go again. So that the player basically can't play without the parent's consent. And then they're back to play. And that's what the form looks like, and we're looking at, my suggestion is that the various footballing bodies in the area adopt a similar policy. I think it makes sense. It protects the player, it protects the school in a medico-legal sense, or the governing body, and it makes sure that the kid doesn't get exposed to a knock before they're ready. Just with regard to the players that we've looked after for the coaches here, I think the most important thing when it comes to managing kids, whether it's concussion or a kid with Osgood Slatters or a kid who's got a stress fracture or a kid whose quad's fallen off, is that the people that are involved in their management talk, which I think is something that we've improved a lot, certainly between our practice and here in the last year or so. I don't think it needs to be complicated. I think it's important that the coach knows what the kid can do before the kid tells the coach, because I don't think it's right that mum and dad are paying for treatment and we're relying on a 12 or 13-year-old to say to the coach what they can and can't do, because I think that game of Chinese whispers, it falls over, it doesn't work. I think it's important that the coach understands before the player gets back to training that they know what they can do so you can run your session properly. You know which kids are in, you know which kids are out, and if they're not fully in, you know what they can do. So our practice is to complete this form, and it's in terms goes further down, but it's in terms that make sense to the coaches so that they can be in non-contact, or they can be a spare man, or they can be a bouncer, or they're in non-contact training, or they're in full training, but it might only be 2 sessions a week, for example. If they're coming back from a lower back stress fracture, they might be doing 2 sessions a week here, 2 sessions a week at the Mariners and playing their game. So that would be limited availability, but restricted sessions. And that's something that we certainly pride ourselves on, and making sure that we communicate with the coaches in terms that make sense to them. Not the kid can play at 50% or 70%, that you know exactly what they can do and exactly what they can't do, and that the player knows as well. So we'll fill out that form in the clinic, take a photo of the form, text it up to Patrick, and then Patrick forwards it on to whichever coach that player is with. But I think overall, like we've talked about a lot of the bad stuff, it's important that kids learn that it's a contact game and things are going to happen at times, and you're going to play with injury at times. The players that make it are not just the best technical players, obviously. They're often physically better in terms of they're quicker, or they can run all day, or they're bigger, taller, stronger. They'll have a physical attribute that separates them from the pack. But what they've also got to have is the ability to know what they can play with and what they can't. And copping a knock early and getting up and getting on with it and learning that you can play with pain is actually an important part of developing as a footballer. There are some pains that they shouldn't play with, and that's why I've identified some of those things today, so that as coaches and parents you can recognise what they are, because the kids will be some kids might be the first to complain, and you need to work out what's important and what's not and tell them, no, you'll be right, get on with it. And that's happened. We've had kids brought into us, and sometimes they just need to hear it from someone else. You'll be fine, get on with it, go and play. But some other problems that they do need to get help with, but players that make it to the top work out what they can play with and what they can't. And that starts from a young age. We're not about putting them in cotton wool. We don't want to stop them. We don't want them to learn that whenever they play, they get told not, or whenever they get pain, they get told not to play. We don't want them to learn that reporting a problem means they're going to get left out. We want them to learn that there are some things you can play with and some things that you shouldn't. And I think that process is an important part of a young player's development. If in doubt, get checked, but don't get checked with the expectation of getting shut down. Get checked by people that understand what they're doing, that understand the game, and that want to keep them going. Like I've always seen our job is to rule them in, not to rule them out. Rule them out's very much a last resort, but if we have to, then we have to. But we'll do it with good reason. And for the kids, preventing injury is far easier than getting over injury. The biggest predictor of injury in an adult is the injury you've already had. So past history and getting older are the two biggest causes of injury as you get older. So it's important that you don't, at 16, 17, 18, develop problems that are going to cause you issues later on because you didn't get looked after. So working on your strength, working with your fitness coaches, working with your coaches in your warm-ups, improving your strength. Like the most common injury in the game, 20% of injuries in football, depending on which study you read, are hamstring strains. Okay, and recent research has shown us a lot of things that are really effective at reducing the rates of hamstring strains, particular types of exercises. So when your coaches say, do your Nordics or do your deadlifts or do whichever type of hamstring exercise it is, then do it. Because the likelihood is you're 3 or 4 times more likely to sustain hamstring injuries if you've got low strength than if you've got good strength. And that can start at a young age. At 14, 15, 16, 17, muscle strain injuries are uncommon. They happen, but they happen not very frequently. As you get older, they happen more and more. So it's important to start developing that strength when you're young and listening to your coaches. And the most catastrophic injury in the game is probably your ACL rupture, which happens. You know, they're not all preventable either. But again, there's really good research to show that if your single leg control is good, if when you're single leg squatting and when you're landing and when you're changing direction, your hip, your knee and your foot stay in a straight line, the chances of an ACL injury, they don't happen when your hip, knee and foot stay in a straight line. So your exercise in the gym, working on your step ups and your aeroplanes and your step downs and single leg squats and all that sort of stuff, anything that improves your ability to keep your hip and your knee and your foot in a straight line can really dramatically reduce the risk of an injury that can really affect careers. Plenty of people have an ACL injury, come back and they're fine. But they're fairly high rates of them happening again, and they happen again more commonly in the people that don't have very good control. You can do everything right, and things sometimes still happen. But if you don't do everything right, then the likelihood of things happening is much, much higher. So that's the message we wanted to get across to the parents and the kids and the coaches. We hope you found what we've talked about today useful. Again, we're not looking to scaremonger. We're not looking to create business. We're just looking to make sure that people that do have problems get the help that they need. So thanks very much for the invitation and thanks for your time. Cheers.